Good afternoon. Welcome everyone to the first meeting on the Senate Committee on Health and Human Services for the 83rd Legislative Session. Madam Secretary, please proceed to call the roll.
Senator Lang. Senator Stone. Senator Taylor. Senator Titus. Chair Doniate.
And I am here. All members are present. Thank you. Good afternoon, everyone, and welcome to Senate HHS. We're very excited. We have a lot of very exciting presentations for today's agenda. As the same way that other committees have started, we're going to start with introductions, followed by the adoption of committee policies, and then we'll do a brief overview of the intentions of the committee, followed by a few presentations from some of our departments. Just as a few housekeeping items before we start, I would like to just make a few announcements. First, the Senate Committee on Health and Human Services is scheduled to meet at 3:30 p.m. on Tuesdays and Thursdays, and we will try to begin each meeting on time. We did face a few technical glitches this afternoon. They're working to fix them as we're starting the meeting. Just as a notice, that agenda items may be taken in a different order than listed, and we may combine agenda items for future consideration. For those who are willing to testify, if you wish to testify, you can sign in at the table by the door or provide a business card to a committee secretary. And if you do not wish to testify, you may also sign in there so that we have a record of who you are. The chair or the member of the committee may request testifiers to submit documentation supporting their testimony. And when testifying, we ask for folks to turn on their microphones on to speak and off to listen. And as a reminder to all those to testify, pursuant to NRS 218E, it is unlawful for a person to knowingly misrepresent facts when testifying before a legislative committee. In addition, the committee exhibits may be submitted electronically as a PDF file to our committee manager, Leslie Sexton, by no later than noon on the business day before the meeting. And anyone who wishes to receive the copies of the committee's exhibits can go to the Nevada Legislature's website. There's a lot of housekeeping announcements that they added on. And then finally, please turn off any electronic devices, especially cell phones, or put them on silent during the meeting times. Let's go ahead and start off. I would like to take a few minutes to introduce members of the committee and committee staff. We're going to do first the committee members, and then we'll go staff one by one. So let's start with just your background, if you've served on HHS before, your interest in health and human services if you haven't had the chance to. And then because it's health and human services, I always like doing a fun question. So let's do the opposite of healthy things. What's your favorite candy? Let's do that. And then that also goes for our presenters too. Let's start with our vice chair.
Thank you, Mr. Chairman. My name is Angie Taylor. I am excited to be on HHS and certainly to be the vice chair for this fine gentleman to my left. I served I served one term in the Assembly, Nevada State Assembly, and I was on HHS then as well. So I was excited to be able to continue that work. And favorite candy? Ooh, it depends on what mood I'm in. I'm gonna go with peanut M&Ms.
Lovely. Senator Lang.
Good afternoon. I'm Senator Lang. I represent, I'm Senator for Senate District 7 and also the Assistant Majority Leader. My district is in Clark County. It's by UNLV and then goes all the way east. This is funny. I am an educator by trade, and I chaired education last year, and I also was on HHS, and I really realized how much I really like it, and half my bill drafts this year for HHS. So I've grown a real interest because it affects so many people. It affects everybody, right? Everything we do. So I really enjoy being on this committee. My favorite candy, I really like candy a lot. So it's hard to choose, but I love Williams and Sonoma peppermint bark.
Thank you, Senator Lang. Senator Titus.
Thank you, Mr. Chair. It's an honor to serve on this committee with you again this session. I'm Senator Robin Titus. I represent District 17. I'm a medical doctor. I represent 6 rural counties, so basically the whole western side of Nevada, starting at Douglas County, all of Lyon County, all of Churchill County, all of Mineral County, all of Esmeralda County, and part of Nye County. So it's important to me to represent rural issues, but also healthcare issues, having been a doctor for more than 4 decades now. Proud graduate of University of Nevada, Reno. So I am thankful to be on this committee. It's my 6th session, 4 in the Assembly, always on the HHS, and 2 in the Senate now, and again on HHS. So thank you for allowing me to serve.
Did you say your favorite candy? Did I miss that?
My favorite candy is dark chocolate with a really good port.
Good choice, Senator Stone.
Thank you, Mr. Chair. It's an honor to be on this committee again with you and my colleagues. My name is Senator Jeff Stone. I represent the 20th District, which is the southeastern portion of the tip, if you will, of Nevada, going through my hometown of Henderson, northerly all the way to Mesquite, and southerly all the way to Laughlin. I'm a pharmacist by profession. I've owned and operated 6 pharmacies. I've taught pharmacology at the university level. I have a beautiful wife, Regina, 4 children, 7 grandkids. 3 of the 4 kids are lawyers, which are interesting. None of them went into the pharmacy business because they were stocking shelves when they were 2 years old. And my favorite candy bar is Almond Joy.
Thank you so much, Senator Stone. Our legal counsel for the committee, Eric Robbins, isn't here, so I'm going to go next to Ms. Cooper.
Good afternoon, everybody. Destiny Cooper, Research Division, Legislative Counsel Bureau. My background is in public health. I have 2 degrees from the Better Nevada University. And my favorite candy is, well, first I served on Senate HHS last session as well. During the interim, I served on seniors, vets, and adults with special needs, as well as the Silver-Haired Legislative Forum. And my favorite candy is Sour Patch anything.
Thank you so much, Ms. Cooper. Ms. Sexton, Leslie. Do you want to use a mic? That way folks can hear you virtually. I think it's more for the recording. That's why.
Thank you.
Yeah.
My name is Leslie Sexton. I'm the committee manager. I'm retired 30 years in the labor movement. My interest in health and human services is that I negotiated health benefits. I also served on a Taft-Hartley benefit fund. After I retired, actually I went to work for Nevada Primary Care Association and educated on the Affordable Care Act, as well as serving as an enrollment assister for the health exchange. And this is my 4th session here.
Thank you. McKenna?
Hello, my name is McKenna Melvin. This is my first session as a Health and Human Services Secretary. During high school, I was a member of the Future Farmers of America, FFA, as an officer and just a member for 3 years. I was also an acting manager and journalist for my VEX robotics team. And I have a deep passion for music and literature and write in my spare time. And my favorite candy is a Kit Kat.
Thank you. Norma?
Good afternoon. My name is Norma Millette, and I am the Committee Secretary for Health and Human Services. This is my 4th legislative session. I retired in 2013 as the Personnel Officer for the division, it used to be called Mental Health Services, but the Division of Public and Behavioral Health for the Department of Health and Human Services. Prior to that, I was employed with the Douglas County School District for 8 years as their personnel director. And prior to that, I was with Washoe County as a personnel analyst, having worked with all the departments in the county, including sheriffs and Truckee Meadows Fire and all the various departments in the county. Before state service, I lived in Maui and Santa Barbara. I opened the Westin Maui back in 1984, where I was employed as a director of guest services. And then after that, I moved to Santa Barbara, where again I worked for the Santa Barbara Biltmore Hotel as a director of guest relations. I moved to Reno in 1983 and to Minden in 2000, where I met my husband, Jimmy, and we married in August of 2008 after being divorced for 25 years. So I guess I finally found the right one. And let's see, we have 3 children between us, and my passions are traveling, cooking, and singing with Jimmy. And my favorite candy is Lint's dark chocolate truffle. Thank you.
Thank you. Syria?
My name is Syria Sosa, and I am really glad to come to work for Senator Doñate as well as the wonderful team of HHS. I was born and raised in Juarez, Mexico, which is the border city across from El Paso, Texas. For almost 40 years now, Las Vegas, Nevada has been home to me, my 2 sons, Cesar and Alexis, my daughter-in-law, Alicia, and my grandchildren, Axel, Levi, Cesar, and Eggy. My employment with the LCB, Legislative Council Bureau, started with the Las Vegas office when it first opened in December 1994. As part of a staff of 3 employees, being the only outsider selected from over 100 candidates. I was a lucky one. I was the first fully bilingual employee hired by Director Lord Malkovich at the time. He believed that my Spanish skills would be useful in the future. And as such, I have been able to create hundreds of documents in English or Spanish. The 1995 legislative session was my first, and 2025 is my 15th. So that marks my quinceañera anniversary. And I'm happy to be here with Senator and the wonderful team that I have with HHS. Thank you.
Syria, what's your favorite candy? Can't walk away yet.
That's gonna be dulce de leche. It's a Mexican milk candy.
Good choice, good choice. And last but not least, we have Leticia, if you want to come step forward.
Hello, everybody. My name is Leticia, and I'm interning with Senator Fabian Doñate this legislative session. It is my first one. I'm currently studying at UNLV, Go Rebels, where I am a Bachelor of Healthcare Administration. I also serve as a community overdose response trainer and a research assistant for the College of Education. It's very nice to be here. My favorite candy is a Mexican Duvalin.
Thank you so much, and thank you so much to our staff for their introductions. I'm Fabian Doñate. I serve as a chair for this committee. This is my 2nd time chairing Senate HHS. I was elected in 2022, appointed in 2021. Have served in HHS now for my 2nd legislative session. So just very honored to be here. A little bit about my background. So I studied public health at UNLV for one simple reason. The reason was that when I was younger, as a teenager, I had to translate for my father when he got diagnosed with type 2 diabetes. It showed me a lot of the injustices that we have in our healthcare system, and so I devoted my life and my advocacy to making sure that no children or a child would ever be placed in a similar circumstance. I mentioned that because I'll bring it back later on in a few weeks. My philosophy for the committee is the same as we've had before. I think that there's obviously a lot of national rhetoric and fear of what's going to be happening under the new administration, and so I'm very cognizant of the efforts that we can do here statewide. My 3 priorities for this upcoming legislative session is, number 1, I want to maintain the stability of our healthcare system. Many of us know that Nevada's healthcare system is very fragile, and so I want to make sure that we address the needs of our state. Number 2, that we build on our past progress. Collectively, we worked really hard together to pass bills that, we've tackled, from homelessness to public health to vaccinations. And so I want to make sure that we're continuously leading on that track to improving our rankings. And last but not least, ultimately, we want to make sure that no Nevadan gets left behind or forgotten. I think that we're going to hear many stories of people who have had struggles with the healthcare system and making sure that we deliver to them. And so ultimately, right, it's the same mission that I shared when I chaired the interim Health and Human Services Committee, which is our work and our progress will be measured based on how many bills we get passed bipartisan, because ultimately healthcare impacts all of us, not just one party or another. So I want to make sure that that's reflected in the work that we do. And yeah, let's get to work. So with that, we're going to start first with our first order of business, which is the adoption of committee policies. These are posted on the legislature's website. These policies are pretty standard and similar to those that have already been approved in other committees, and so I will go ahead and ask if there are any questions with the committee policies at this time. If not, I'll go ahead and take a motion to adopt the committee policies for the Senate Committee on Health and Human Services. And we got a motion from our vice chair and our second from Senator Lang. Any discussion on the motion? All those in favor, please say aye. Aye. Any nays? The motion carries. That was pretty fast. All right, let's go on to the next one, which is a presentation on the committee brief. We'll go ahead and have our policy analyst, Ms. Cooper, present on the committee policy brief. So please begin.
Thank you, Chair. Destiny Cooper, Committee Policy Analyst, Research Division, LCB for the record. I will provide a short overview of the committee brief. Each member should have a copy in front of them. This is what the document looks like if you're in person, and then it's also on Nellis. Before I begin, I would like to remind the committee that as nonpartisan Legislative Council Bureau staff, I can neither support or oppose any measure this committee will consider in the next 117 days. I am here to provide unbiased policy analysis and research to the chair and the committee members. Diving into the committee brief, you will first find statistics on the number of measures considered in the 2023 legislative session, an overview of the committee jurisdiction, and potential topics to be considered during this session. During the 2023 session, the committee considered a total of 79 bills and resolutions, with 58 of those being passed by the legislature and delivered to the desk of the governor. These measures span a broad array of policy issues, including access to care, mental health, behavioral health, public health, substance abuse, and child welfare. The committee brief includes an introduction to some of these topics, with much of the information being discussed and deliberated on by the Joint Interim Standing Committee on Health and Human Services. Included on the last page is the relevant reports, studies, and audits, as well as bulletins from the Interim HHS Committee and the Legislative Committee on Senior Citizens, Veterans, and Adults with Special Needs. These bulletins provide additional insight into the relevant policy areas, along with summaries of the interim BDRs that may be considered by this committee. To conclude, I would like to remind the committee that I am available to assist on any issues before the committee, and please do not hesitate to reach out to the Research Division with any questions. Thank you.
Thank you, Ms. Cooper. Any questions? Vice Chair.
Thank you, Mr. Chairman. I really just have one question. What's your favorite candy? You didn't give it to us.
Oh my gosh, the Twix bar. Jesus, this is what happens when I don't follow my own directions.
I'm here for you.
Any other questions? Senator Titus.
Thank you, Mr. Chair. Just out of curiosity, just looking at the number of bills that were referred to this committee, and I do appreciate kind of a general concept of what, but how did we get more bills that became law bills that became law? Never mind, I got it figured out. Sorry, I asked a question. He vetoed quite a few HHS bills, I must say.
I must say.
No comment.
So let's not do that.
Yeah, I don't disagree. Any other comments before we move on? All right, let's go ahead and go to, we're going to start on our presentation. So today it's a very good occasion. We have a few agencies and departments here to give us just a general overview of the healthcare landscape in our state. Obviously, we'll have the chance to ask questions, et cetera, afterwards once we go through them. So let's start with the director's office presentation, if that's okay. I don't know if we still have the technical glitches, but we can. The exhibits are obviously posted online if folks want to follow along. So. And Director Willie, you can present. You can go when you're ready.
Thank you, Chair Donate. Members of the committee, we actually had opted not to do a PowerPoint today, but just talk about our agency briefly and then follow up with each of the divisions. So
that's good, but don't forget about your candy.
Okay, I'll get. I like black licorice. Back on task. Richard Whitley, Director for the Department of Health and Human Services. We have one of the largest agencies in state government with over 7,000 employees. We're organized in divisions. The Division of Healthcare Policy, Healthcare Finance and Policy, which is Nevada Medicaid, the Division of Welfare and Supportive Services, which largely does eligibility for a variety of programs, including Medicaid, but with different poverty levels and eligibility requirements, but they primarily do eligibility. Followed by 3 divisions that really work in the space of funding services and providing direct services, and public and behavioral health. Administrator Finney probably has the largest scope of direct services with hospitals and care for adults with mental illness, followed by the Division of Child and Family Services, which really has a unique role in terms of providing the safety net services for child welfare in rural Nevada, and also some, well, much like the adult system in criminal justice, which is fairly fragmented really with roles between the county and the state. The state is responsible for parole and for higher level institutional care, where the counties do probation and do have juvenile facilities while kids are waiting for adjudication. So some unique roles in terms of the service span in DCFS, and then finally aging and disability services. And they manage our waiver program for people living with disabilities. And one of the things that I was going to talk about briefly, and people who sit on the money committees heard a bit of an overview of our proposal to reorganize our agency. I don't know if it'll come through here with it's a budget bill. So the policy's embedded in the budget bill. But the intent of that, which Stacy Weeks will talk about, the purchasing power, really, which is like a nice summary saying of coordinating efforts and how we purchase healthcare. She will share more about that in her presentation. But what that allows us to do on the human service side is really focus on some populations, like the aging population. When I mention child welfare, or even public health, those have systems locally, agencies. We really don't have one for seniors. Counties play different roles, community nonprofits play different roles, and so I'm really looking forward to if our reorganization is approved, to then be able to focus on some areas more on the social services side. You know, like one program that we're proud of is our senior Meals on Wheels, which is really not a food program, it's a welfare check. And it was so wonderful during the pandemic. Catholic Charities provides a lot of those services in Las Vegas. In Washoe County, the county contracts that out. Various nonprofits kind of patched together, but what they did was check on people when they were vulnerable, provide, all can't travel out amongst a lot of people. We didn't have adequate protective equipment and things. They fed the pets, they fed people, and they checked on their status and asked for higher levels of help if the individual needed it. So I'm really excited in that space. Administrator Dina Schmidt is excited as well to spend some time diving into developing a system that we can support and really have impact on aging as healthy as possible. Most at a federal level, this change occurred years ago, but Medicare used to be the big payer for skilled nursing homes. They're not anymore. Medicaid is. They pay for time-ended stays. So really the drive is to age it at home. If you have a home, age at home as safely as possible. So what Medicare has done is wrapped around a lot of services for in-home, from from personal care to hospice to home health agencies to try to help people live as independently as possible. Easier said than done. Assuring that people are getting those services and their quality, I think, are just that one population that I think we're all going to be, hopefully, and we have family members who are, and helping them to live as safely as possible. I think that's exciting work ahead of us on the human service side. You know, we largely deliver direct services as well, serving as the state's safety net in children's behavioral health and adult behavioral health. I think we could do a better job defining what that means, particularly on the children's side. What are the elements and what are we looking at that we need to play that role? We have a beautiful children's hospital in Las Vegas, not completely full, hard time staffing. Hopeful that we'll be supported since we really use a hybrid model of contracting out for services, and if we can't hire people, then we should contract it out. It's hard to find facilities, and so we're putting forward some ideas and some things that we could do business differently in this environment, and a lot of it we learned out of the pandemic. And I just would give one plug too on the human service, on this direct service side. We've talked about reorganizing before, and it's always been on the direct service side, but it was with the touch point like to Department of Corrections, where they provide medical care and have probably more struggles than I do with getting staff to work in remote settings and having medical events. Many of their the inmates in the prison who have mental health issues pass through the state mental health system when they were living in the community, and they'll get back out again likely and need more support. I think that there's some synergy there to work on over time with direct services so that we can all be providing the highest level of care possible. Again, lessons learned through the pandemic, hard to hire people, but the care didn't go away and the state's responsibility. And I sometimes say that, like, we have to break policy sometimes to run a hospital. And it's just the way it is because government's not built to really respond to direct service needs. And I'm so proud of the staff we have that do direct service that, they put patient safety first, and I totally support them in that, in defending how they provide, that they have, and they stayed accredited, Joint Commission accredited throughout as well, which is not always easy to meet all the requirements. And so I just say to you that there's opportunity as we look at direct services for us to equally grow something there that benefits the entire state as we go forward. I think that's all that I have for the department, and you'll hear a deeper dive for each division.
Shannon Litz, Deputy Director of Programs for the Record. I'll lead with my favorite candy of York Peppermint Patty, and I'm going to go over some of our programs that are located within the Director's Office for HHS. So we have the Fund for Resilient Nevada, which is our opioid settlement funds. Through the Grants Management Unit, that includes the Fund for Healthy Nevada, which is the tobacco settlement funds, the Office of Minority Health and Equity. We have the Governor's Council on Developmental Disabilities, the Office of Analytics, and Individuals with Disabilities Education Act, or IDEA, Part C. And just to touch on a couple of those, the Office of Analytics, it comes up a lot. We have a wide variety of dashboards and reports. They're posted and available online through our website. One that we thought might be of interest to this group is our community health profiles, and that really summarizes the health indicators by each district, and it's also available statewide. That's located on our homepage if you look under quick links or at dhs.nv.gov/analytics. On the side for Fund for Resilient Nevada, for our opioid settlement funds, a reminder, many of you have served on other committees and have heard about this, that 43% of the opioid litigation recoveries are managed through the Fund for Resilient Nevada. Local governments who are part of the One Nevada Agreement do also receive funding directly. The annual report for Fund for Resilient Nevada just posted last week, and that offers a lot of information on the 7 identified goals that the fund is working through and all the projects that are in progress. Through Fund for Resilient Nevada, we do also have an online dashboard. As of now, it's current as of last summer, with information on spending for each of those goals, as well as our total opioid recoveries. So appreciate the time, and we're happy to take any questions.
Thank you so much. Committee members, do we have any questions for them? Senator Lane.
Thank you. Deputy Director, I'm wondering if you, I'm going to have a bill later, and I'm interested in the opioid settlement funds and how they're distributed and kind of where we are. If you could get that to me, I'd appreciate it.
Shannon, that's for the record. Happy to get you some information.
Thank you, Senator. We could also, if we wanted, if the committee is interested, we can schedule probably, I know there's work that the search committees have done, et cetera. Maybe we can have a deeper dive at a later date in an HHS committee if we wanted that. So any other comments or questions? No? All right, we'll move on to the next one. I'm going to pull the next one. We'll do DPBH if that's okay, Ms. Finney. And then after that, we'll do Aging and Disability Services.
Shall I begin? Thank you so much, Cody Finney. I serve as the administrator for the Division of Public and Behavioral Health, and I have with me today Drew Cross, who is our statewide forensic program director, in case there's any questions about the technicalities of that very specific program. I brought just a few basic slides about the division, just to have at your fingertips some of the most basic of our information. So on slides 2 and 3, we highlight our mission, vision, and purpose. We really do come to work to make the life of everyone in Nevada healthier, happier, longer, and safer. And so we spent some time in this last interim working on our mission, vision, and values as part of our preparation to apply for accreditation with the Public Health Accreditation Board. And we're very proud of that work that's been done. On slide 4, it's just our organizational chart as we currently stand that shows how we're divided up and who the leadership roles are. I intended to go through this pretty quick so y'all could ask questions. Is that okay? Yeah, excellent. Okay. On slide 5, it's our operational unit highlights. And you can see there that it is a very, as the director mentioned, it's a very large organization with a broad array of services. We have our community and public health services that's kind of the traditional public health pieces and involves a lot of grant management. Regulatory is overseeing private sector industries, and then clinical services, we're providing direct services to people with mental health needs. So very broad and distinct arrays of services. So on slide 6, we have some accomplishments that we're proud of. In this last interim, we've had some really good success improving our vacancy rates within the organization, and we've done targeted outreach for workforce improvement with our NevadaHealthForce.org website. In our forensic mental health section that I mentioned, we've implemented a multi-pronged approach to addressing the wait time and number of people waiting to be admitted to those services, and we were able to achieve a 39% reduction in that 12-month period. So that was very exciting. There continues to be a growing need for those services, and a lot of what we're focused on right now is addressing those issues. In the public health realm, we've got active participation with the University of Nevada, Reno, and DHHS on an academic health department. This is another workforce development piece that really allows us to have access as we're doing our work to some of the most important aspects of up-to-date research and people that are working in the academic field. We did submit our application for the Public Health Accreditation Board, and they have that. We submitted over 200 documents for them to review. It was an enormous lift, and it included a statewide health assessment, which you can find on our website that's very informative, and a health improvement plan as well. We're, like I said, very, very proud of that work. And we were one of only a few states to be recognized as an age-friendly public health system, really demonstrating our ability to support people across their lifespan. All right, our next slide is the policy priorities we're working on related to public health, the continued improvement of the infrastructure and operations for most effective and efficient organization. We continue to work to build a robust public health infrastructure throughout Nevada that has strong local health authorities. We were working this morning with the Central Nevada Health District that was stood up in this last interim. And our crisis stabilization implementation is really a public health strategy to make sure that people can get the mental health services that they need. On slides 8, we go into some detail about that crisis response system. I'm sure we'll have future discussions about that, but we're seeing some excellent progress. We expect crisis stabilization centers to be open north and south in the first part of this year. I think the northern one, ribbon cutting, is scheduled for the 19th of this month, so we're very excited about that. And the co-location of the new call center in the south with 911 is really huge steps forward that we're making towards that crisis response system being what Nevadans really need. On our public health focus, we are working to transfer, the director mentioned the reorganization for our division. That means the transfer of environmental health to the Department of Agriculture, and that's really about putting those food-related public health efforts all in one place, and making sure that we maximize the capacity of those staff to protect Nevadans. And also moving the healthcare quality and compliance, that's the licensing of most of our health facilities, to the newly formed Nevada Health Authority, again, to keep those like functions together. In infrastructure for public health, I'm on slide 10. We've got workforce development, again, as I mentioned earlier, and some really exciting data modernization initiatives. That data, in order to make decisions and develop programs in public health, is really the foundation of everything. And if we don't have accurate data, we don't know if we're doing the right thing or how to measure it, which is incredibly critical. So modernizing those systems that we have and allowing them to talk to each other so that we can share data readily and make sure that data sets are accurate against each other, high priority. The next couple of slides are our bill draft requests, largely focused on that forensic mental health system. But I will stop there and take any questions you might have.
Thank you so much. Any questions from the committee members at this time? No? I got a few. So I got a few on relating to public health matters. I'm going to start first with, let's start with current events. How about that? There's a few articles that came out within this past week about the bird flu outbreak that's happening in Nevada and how that's impacting farm workers or farmers, et cetera, because it's obviously growing. Have DPBH been in coordination with the Department of Agriculture to at least contain the disease or seeing if it's transcending to humans, et cetera? Like, what are those conversations in lifetime?
Cody Finney for the record. Thank you for the question. Yes, we are in coordination with the Department of Agriculture, particularly our Office of State Epidemiology working very hard on that. Also, our program that is public health preparedness, providing resources in real time out in the areas that are most affected. Also coordinating with the Central Nevada Health District. So we're in regular communications with those folks, getting PPE out to them actually today. So really working to try to limit the impact that will have.
Thank you. Is there anything you want to highlight for us, or any support services or funding gaps that you're already noticing just from the delivery of it?
Cody Finney, for the record, I was just thinking about the meeting we just came from. It's not an immediate. I'm not having an immediate thought on limitations that we have. I will say it's challenging to have adequate epidemiology staff, both related to zoonotic infections like this one, and there just aren't a lot of epidemiologists in the world, and we need to continue to work to build those resources.
Thank you. I want to continue the line of questioning more on obviously current events and what we've seen over the last few years, especially. During the interim, we talked a lot about immunizations, right? This has been a national trend in terms of the mistrust of the healthcare sector and vaccine hesitancy that has existed. Obviously, we saw the news with Immunize Nevada, what have you. The last time that I brought you guys in, there was at least an effort of coordination that was going to happen behind the scenes of perhaps issuing an RFP or something to fill the gaps of now that this entity was no longer going to be there. Walk me through the infrastructure that has been developed since that moment that we last met.
Thank you. Cody Finney, for the record. We continue at DPBH to work with a number of partners. I actually had to have a written list so that I could not leave anyone out. But I mentioned the local health authorities. They are critical in this infrastructure and all working with us on immunization pieces. But we continue to work with a broad array of partners to support anyone who wants to get immunized having access to that. We continue to provide education and outreach about the safety and effectiveness of vaccines. We are, as you mentioned, Senator, in the process actively preparing an RFP to replace that statewide coalition that was so active. But we've not taken our foot off the gas on making sure that people can get immunizations. So one piece that is being done by the Nevada State Immunization Program in our division is those reminder calls to parents whose very young children may have missed a dose that is so important. And so those reminder calls continue to go out. But let me make sure I don't leave off any of our incredibly important partners. UNLV, the Nevada Cancer Coalition, Washoe County Medical Society, Clark County Medical Society, the Nevada Broadcasters Association, Northern Nevada Public Health, Southern Nevada Health District, Central Nevada Health District, UNR, sensory-friendly vaccine kit distribution, and Make the Road Nevada, as well as all the social media platforms that we use from DHHS, all things that are still happening to try to get accurate information out about the safety and effectiveness of vaccines.
Thank you. So kind of in response to that, it's my understanding that Immunize Nevada, when they still existed, they were responsible for a lot of the community outreach that existed in rural communities, right? And holding those stakeholder conversations of not challenging, but combating vaccine hesitancy. And so just to be clear, it's not just marketing efforts that the DPBH is administering in the vaccination program. You're also doing targeted community efforts individually outside of our organizations, correct?
Cody Finney, for the record. Yes, that's correct.
Thank you. As a follow-up to that, have you seen, now that we have this coordinating entity no longer in existence, Has there been a drop off of vaccines since the last time we've met based on the school enrollment that occurred? Is that data already starting to show?
Cody Finney, for the record, we have extensive data on vaccine uptake stratified by a number of factors. I would be happy to provide the report to the committee. I will say it's very frustrating to us in public health. The numbers aren't going the direction we would prefer.
As a follow-up to that, I'm going to come back to that. One of the reporting that we saw from the Nevada Independent indicated that Immunize Nevada still owed the state more than $290,000. Number one, has that state funding been received? And if not, what are the steps that DHHS is taking to receive those funds?
Cody Finney, for the record. No, we have not received any recouped funds from Immunize Nevada. We are working with our representatives at the Attorney General's office on the actions that we can take to recoup that money.
Thank you. Do you have anything to say about the impact that the outstanding debt has had on the immunization programs throughout the state?
Cody Finney, for the record. The outstanding debt is not negatively impacting us at this point. You can see on our charts that budget account 3213, I struggle so when we name everything with numbers, is about 50% federal funds.
That was going to be my next conversation.
No.
It's almost as if
I got ahead.
Yeah. One of the things the reason why I was bringing these lines of questions is obviously there's a politicization of public health, and it's up to the legislators in this state to protect the needs of Nevadans, and that includes vaccine uptake. I know that obviously the CDC provides a level of funding for this immunization program, and there could be a threatening message that could be received for it. Do we know how much of how many dollars? I know this is not the Finance Committee, but do we know how many dollars could be at stake if the federal government chooses to rescind those dollars?
Cody Finney, for the record. So, like I said, that program, I'm looking at the fiscal year 2026 numbers, $8.8 million for the immunization program total. 4.4 of that is federal funding. At this moment, we have not received word. We are in the process of applying for our core immunization grant from the CDC for FY 2026. We have no word from the federal government that will be reduced, and we currently expect about level funding on that CDC grant. So should that change, that would be impactful. But right now, we have no reason to believe that that's a problem.
Thank you. Not a question. Now I get to go to the comment section of why this is all important. Obviously, I know Director Whitley, we sent you your team a letter. Majority Leader Canizaro, Senator Donduraloop, and myself sent a letter. We received the confirmation that we'll be pulling some of the folks back in several weeks to discuss the implications of the federal cuts that could potentially occur in crisis scenarios, right? Because ultimately we have to protect the people of this state. As a follow-up to that, as I was preparing my line of questioning for this conversation that we're having just this moment, literally 2 hours ago, there was a report from the Wall Street Journal that the Trump administration is in the plans of cutting staff from DHHS, the CDC, FDA. If that occurs, right, there's a discussion as to whether or not they're going to be cutting federal programs that are administering, for example, vaccines. The politicization of public health is happening in real time. And so what I want to know, on top of the letter that we sent, right, and perhaps we can do this later in March, is number one, how many Nevada-based public health workers are going to be impacted by these cuts? Number two, what are the programs or public health services in Nevada that rely on federal personnel, and what are the risks if these positions are eliminated? Number three, obviously, if you receive official communication regarding these workforce reductions, what are the steps that the state is taking to prepare for the potential disruptions? And then ultimately, how reliant is Nevada on federal dollars for public health initiatives? I have an understanding of what that is, but I want to make sure my committee members also understand the implications of it. And so I would like to make sure that you work in cognizant with the health districts to quantify what that number is, because if we lose those dollars, right? We worked so hard to pass public health funding that in the last legislative session, we allocated, what, 15 million to it? SB 118. There are very serious circumstances that we could be potentially in for our health districts, for our schools of public health, if these programs are not renewed. And so I want to make sure that we have the answers to that. It's not just Medicaid, it's across the board. And so I just wanted to make sure that I communicate our intention the next time you're in president in front of us. So I don't know if you wanted to say anything else in response to that, but I just wanted to make sure that that was clear.
Cody Finney, for the record, thank you very much, Chair Doñate. We appreciate your concern. We will absolutely continue to get that information for you, and we are watching very closely and in real time assessing the impacts that the information we're getting from Washington, D.C. can have on us.
Thank you so much. Any other questions or anything? We're good? All right, let's go on to number 3, our team from the Aging and Disability Services Division. So Ms. Schmidt, when you're ready, please proceed.
Good afternoon, Chair Donati and members of the committee. Thank you for having me. My name is Dina Schmidt. I serve as the Administrator for Aging and Disability Services. First item on is if you haven't had one yet, the gummy Skittles. They're the best. That is my favorite. So, at Aging and Disability Services, our vision is really that Nevadans, regardless of their age and ability, will enjoy a meaningful life led with dignity and self-determination. We try to empower individuals and their support systems by providing resources for disability and aging. We connect Nevadans to services and improve the quality of life. And so there are several programs across our, as Director Whitley mentioned, we have some direct service programs, we have some oversight programs. I'll walk through just high level a couple of our programs, and then I'll be happy to take any questions. Adult Protective Services is committed to protecting and supporting vulnerable adults by investigating reports of abuse, neglect, and exploitation. The mission of that group is really to prevent any further maltreatment while safeguarding civil liberties. Our long-term care ombudsman is also dedicated to ensuring that residents in long-term care facilities as well as group facilities have the highest quality of care and support possible. Our Autism Treatment Assistance Program is dedicated to ensuring that families, regardless of their financial circumstances, have access to essential treatments and therapies. We provide funding for families with children under 20 who have a diagnosis of autism and who may lack insurance coverage, and we cover those critical services. Our Early Intervention Program provides essential supports at no cost to families, offering specialized instruction, audiology, physical therapy, occupational therapy, speech therapy, and vision services to children 0 to 3 years old. Our Office of Consumer Health Assistance also empowers Nevadans by helping them navigate their health care rights and responsibilities. We offer consumers assistance with their health insurance information. If you get a bill, anybody looks at your hospital bill at the end, it always has their number is on there. So if you have questions, concerns around your payment system or access to any services, really, access to Social Security, access to Medicaid, eligibility, that's what this group is here to do. They can help you navigate these complex systems. Then we have some of our direct service programs. We have several programs that we do operate the waivers, the frail, elderly, and physically disabled waiver, and then we also have programs that are very similar that are state funded that provide similar services. Not all the same services in all those programs, but those services range from in-home services such as home delivered meals, house cleaning, assistance with bathing, grooming, cooking, and shopping. Those services are determined by a licensed social worker who conduct the assessments and then connect those individuals to an actual private provider that is a Medicaid provider. Our developmental service programs offer a wide range of supports through 3 regional centers that ensure people of all ages receive the services they need. These services include family respite support, counseling, in-home training, jobs and day training, as well as employment vocational trainings, and we try to help individuals build skills and find meaningful work. Our residential programs support individuals to gain independence while thriving in their homes and their communities. By coordinating these services, developmental services is dedicated to helping individuals and their families live fulfilling and meaningful lives. Our Office of Community Living, similar to others, oversees close to $28 million in grant funding. Most of these funds are through the Older Americans Act funding to and we fund those out to community providers to provide an array of services to individuals with disabilities as well as older adults. Some of those include congregate meals, home-delivered meals, food pantry. We provide respite and caregiver support, transportation, assisted living support, home modifications and repairs to keep seniors in their homes, adult daycare, medication management, resource and service navigation. We also have a legal assistance developer where we provide legal assistance to individuals, representative payees, Medicare assistance, also evidence-based programs such as pain management and falls prevention, assisted and on Office of Independent Living Services, which really focuses on folks with physical disabilities and providing assistive technology, communication access. And then to round all that out, we have our quality assurance team. So we have created a quality assurance team around all of those programs, and with the legislative support over the last few years, we've really been able to grow that team and create consistent processes. And in fact, one of our programs was nationally recognized for their review process. So we're really proud of the work that they're doing there to improve the services that we do provide. And then I'd like to just finish up with kind of the bigger picture for health and for aging and disability services. There's estimated to be 269,000 people in Nevada over the age of 5 who have a form of disability. And approximately 2.3% of our state's population experience difficulty with performing activities of daily living, such as dressing, bathing, and getting around inside their home. As we all know and have talked about for years now, the aging population is growing. The population over 60 is projected to reach 17% of Nevada's total population by the end of this year. To put that in context, between 2012 and 2022, the number of adults over 60 increased by 42%. This does put pressure on all of our social systems, right? And how do we start to continue to meet this demand is one of my concerns as the Administrator of Aging and Disability Services. As Director Whitley mentioned, we really need to take a look at this area and take a focus on how do we contain these costs, and how do we provide services across the lifetime, right? How do we keep people healthy from birth to death, not just once they're older, right? So how do we create systems? And really looking at how do we contain these costs. I just want to give you a couple of, just from my perspective, I started this role at the fiscal year, ledge-approved budget of fiscal year 17. In that year, my ledge-approved budget was 290, let's see, I'm going to have this wrong here. Fiscal year 17, ledge-approved budget was $291 million. In 27, with the governor's recommended budget, $702 million, 141% increase. That is not sustainable. My FTE count when I started was 960 staff members. With the governor's recommended budget this session, 1,672 staff. That's a 74% increase. So as you work through this session, I would just encourage us all to work together to figure out how do we resolve health issues. And I say that they don't belong to disabilities or health, it's across the lifespan, right? One strategy that's been emerging amongst other states that I'll just throw out is it's a 10-year blueprint to try to guide states on restructuring their local policies and programs. Some states call them a multi-sector plan on aging, some call them a master plan on aging, others call, and there's many names, really doesn't matter what you call it, but it is really a roadmap to look at how do you transform your infrastructure, how do you coordinate services across systems, so across your transportation systems, your public health systems, your community development programs. It's really going to the community, gathering input from everybody on that touches healthy living and how do we create systems that improve and contain costs and improve outcomes for people. So with that, the only other thing I wanted to mention is we do have 2 bills this session. One is just SB 8, which I think we'll be hearing next week, straightforward cleanup bill, just a language, and AB 6, which is our making fetal alcohol syndrome a permanent program in our autism treatment assistance program. So with that, I am happy to answer any questions.
Thank you so much. Committee members, any questions? Senator Lang.
Hi. In your autism work that you do you coordinate with the schools at all?
Dina Schmidt for the record. So we do coordinate with, the Ackerman Center, which used to be associated with UNLV, we work a lot with them, and then we also work somewhat with the University of Nevada UCAN program. And I apologize, I can't remember what that acronym stands
That's okay.
for.
So you don't do anything with like K-12?
Dina Schmidt for the record. So we don't have any formal coordination with the or with the school systems. We're just the university systems for the diagnosis side of it. We do provide services we try to coordinate referrals from school districts. One of the challenges that we find is the school district's definition of autism doesn't always meet the same as our definition of autism. And so sometimes children might be diagnosed with autism and receive certain services through the school, but those services may not be available to them outside of the school system.
Yeah, I'm actually looking for accountability for what's happening because I'm not hearing good things. And so I was just curious if you had any coordination. Thank you.
Thank you, Senator Lane. Senator Dice, did you have a question?
Thank you, Mr. Chair. Can we revisit those figures that you gave regarding the numbers of FTEs that you had, and what was the date on that, and what the governor's asking now?
Dina Schmidt for the record. So in our fiscal year 17 ledge approved budget, our total FTE count was 960. And in the FY 27, so the second year of the biennium, the governor's recommended FTE count is 1,672. And just to keep in mind, that is all related to caseload, right? So our budget in ADSD is caseload driven. So the demand for services increases.
And that was my point. I think and that will have waiting lists, because one of the things that we've always asked, this body has held you to, is how big is your waiting list, and we want you to decrease your waiting list, and that requires person power.
Dina Schmidt for the record, absolutely. So for just to put it into perspective, in my waiver programs, for every FTE, one social worker can serve 50 cases. So for every social worker I'm able to hire, I can serve 50 individuals on that wait list.
And then again, if I might, Mr. Chair, so in 2017, what was your caseload, including, say, your waiting list? Where I'm going with this is this need for more people is, again, because we have increased our population, and maybe even change some definitions, like you said, and so more people qualify for this. And I just want to make sure what we see in the request is because of the need, as the need has expanded. So do you have those numbers?
Dina Schmidt for the record, I don't have those numbers with me, but I'm happy I can get those for you.
I think that would be helpful
follow-up.
for justification as our population has increased, but not just the population, the identification of certain needs of our population. And so now we are always coming after you about, well, what's your waiting list and how do you solve that? And you solve that by, as you said, more social workers, and we're working on that solution too if we don't have the people to solve those issues. So there's so many facets to this that really need to be, I just didn't want to go off as the governor has inflated his budget. We've demanded that the governor have more full-time equivalents because we are demanding that you address these issues and that we don't have waiting lists.
Dina Schmidt for the record, I absolutely agree. I think that's my point, is the demand is getting to the point where we can't keep up. And so what can we do? And I would just like to highlight that we have had a lot of success hiring social workers in the last 6 to 8 months. So between the raises that were granted and some initiatives we've been having, we now provide scholarships for social workers and for our staff who are going to school to finish their social work degree. So we have made a huge dent in our vacancy rate among social workers, but we're not there yet.
So that's my final question. All right, of your FTEs, what % vacancy rate do you have now?
Oh, I thought I had that.
Sorry.
Oh, Dina Schmidt for the record, I don't have it with me. I thought I had it with me. I apologize. I should have had that with me, but I will provide that to you.
Great, thank you.
And so you want the total vacancy rate, but what % of those are social workers?
Yeah, yes and yes.
Okay.
Thank you.
Got it.
Thank you, Mr. Chair.
Any other questions? Seeing none, thank you so much. One last thing, you mentioned the multi-factor plan for aging. If you can send that to us, I would love to read it and see what other states are doing for strategies on this. So.
Ms. Schmidt, for the record, so yes, we did participate with public and behavioral health, aging and disability services, and the housing division. We had a technical assistance grant where we worked with an organization to learn more about it. So we have information from several states on what they've done, and so I'll be happy to share that with the committee.
Thank you. And it has policy recommendations, correct, in it?
Yes, some of them do.
Lovely.
Yes.
Thank you. All right, let's go ahead and move on to the next one. Division of Child and Family Services. We have Administrator Ms. Marla McDade-Williams. So please begin when you're ready.
My first success. I got the slide to start. Good afternoon. Marla McDade-Williams. I serve as the administrator for the Division of Child and Family Services. And my favorite candy is almond bark from the Chocolate Nugget in Washoe Valley, and there's also one out in Mound House if anybody's interested. I want to begin by just introductions of my team. Oh, now the next challenge, advancing, so that you can see the items that we're set to discuss. Introductions for my team. So down in Las Vegas, just in the audience, Jacqueline Wade, PhD, LCSW, who is our Deputy Administrator for Children's Outpatient Services and Residential Services. Betsy Crumrine, who is here in the audience, LCSW, Deputy Administrator for Child Welfare. And then we have Sharon Anderson, who is a CPM, MSW, Deputy Administrator over Juvenile Justice Services, who I don't believe is in the audience. And then Lorianne Molina Lovell, who is our new, she has a PhD and is our new Deputy Administrator for Support Services. And then Kyra Morgan, who is here, who has an MS and is our medical epidemiologist, who we are so appreciative to have. The mission of the division is to, together in genuine partnership, to serve families and communities, provide support and services to assist Nevada's children and families in reaching their full human potential. And we do recognize that Nevada's families are our future and that families thrive where they live in safe, permanent settings, experience a sense of sustainable emotional and physical well-being, and receive support to consistently make positive choices for family and the common good. The slide is pretty small. It is our summary of division operations, but essentially you can see it's broken out into 4 primary areas: juvenile justice services, children's mental health, child welfare services, and administrative and support services. So what I would like to say is juvenile justice services and child welfare services are our statutory mandates to do. And then when it comes to children's mental health, well, we have some permissive authority to manage facilities. We don't have any direct mandate to provide certain children's mental health services. We do, as the Director Whitley noted in his comments, serve as a safety net and fill gaps in the system. And so most of our children's mental health, although some of it is state general fund dollars, others of it is grant funding. So we're dependent on grant funding and staff who identify gaps in the community and develop programs to meet those needs. One of the needs that we meet in the state of Nevada for children's mental health is early childhood services, and we specialize in early childhood services. So in terms of our legislative priorities, you can see them listed there. I don't believe any of them are coming before this committee. I think we're all going to be in Judiciary Committee. Most of the child welfare and adoption run through Judiciary, as well as our juvenile justice activities. But you can see the list of the measures that we will be working on through the session: 2 budget BDRs and 2 policy BDRs. In terms of updates from the interim, you can see that, again, there are some recommendations that came out of the interim studies. There's a recommendation related to categorical grants for adoption assistance, one related to the adoption of children and adults that makes changes to adoption, another related to immunity for reporting child abuse and neglect, and then another one related to the Office of Children's Mental Health and Behavioral Health, and that one may come to this committee, I'm not sure yet, but none of those measures have any bill numbers assigned yet. On the next slide, these are items that will more likely be going to the interim committee on judiciary. But again, just for your awareness. And really, that concludes my slide, and I am available for any questions.
Thank you so much, Administrator McDade-Williams. Any questions, Senator Titus?
Thank you very much for being here, and thanks for years of service and helping. I'm just curious, prior to coming to this meeting, I sit on the Northern Nevada Regional Behavioral Health Policy Board, and we had a statement from Nikki Aker, the head of the Division of Health here, and she was commenting that there was 60 children identified in Carson that live in hotels that they have a roof over their head, but that's not considered, they're homeless is what under certain definitions. Do we have and I was surprised at that actually, and so do we have any information, because on your page 4 it says your job is to make sure children live in safe, permanent settings, and so do we have a head count or any estimate statewide how many of Nevada children are not in a permanent setting?
Thank you for the question. For the record, Marla McDade-Williams, if I may respond to the senator, I would have to look up that information and see. Again, from our perspective, we are looking at Children's Protective Services and child welfare and ensuring that through those systems that we are providing safe homes for children. The general, the broader system of someone being homeless doesn't necessarily come under our purview, although we do respond sometimes. We get calls that, homelessness is a neglect issue. But, when you look into it, they really are a family and they're doing the best they can. And we have a shortage of foster care homes, so it's not like you can just, take someone and away from their families when they're being cared for. But that issue is a tough one. I will see what data we have out there that we can provide back.
Right. I was surprised, and then I saw that one of your mission statements is that the children live in safe, permanent settings. And so that implies to me that they're living in safe settings and that you are engaged in that process. And so I'd appreciate seeing how many numbers you might have on your files. Thank you.
Thank you so much, Senator Titus. Any other questions? Nope. All right, let's move on to the next one. Thank you so much. We'll go to the Division of Healthcare Financing and Policy, Administrator Stacy Weeks.
Good afternoon. Whoa. Good afternoon, committee members. I do have a slide deck. I'm going to pull it up really quick. All right. So today, and just based on the requests that came forward, we are focusing on Medicaid and DHCFP, if that's okay. I'm happy to come back and talk more about the Health Authority and other things if you guys want to dig into that, but just in the interest of time, I'll stick to that if that's okay. All right. All right. Our mission, I think you guys probably know this, is to really ensure Medicaid is provided in the most efficient manner, including maximizing federal funds, promoting access to quality health care, and restraining the growth of costs to health care in the state. Right now, we have a full team. It's very exciting. I think last time I sat here in front of you, I did not. We are definitely fully staffed right now. Actually, our vacancy rate, I just got notice, is 8.5%. If you don't know, at least I think us administrators are a little competitive at times, and so I think I might be neck to neck with DWIS, but we'll see when Robert testifies. But we're very excited about 8.5%. That's a huge win for us. As you can see, we have 3 clinical leaders on our team. We have a dental officer, we have a medical director, as well as a pharmacist. It is really great to have the clinical expertise at the table. Dr. Duncan recently joined our team and has just been an amazing asset, honestly, and all of our clinicians are great, and Dr. Benson's been leading a lot of our efforts around ensuring that adults and youth with intellectual disabilities, developmental disabilities, are getting access to dental. Dr. Clemens is based in Vegas, and so we referred to her on various benefit needs and looking at our benefit coverage. I'll move to the next slide. So just a real quick snapshot of Medicaid in case I think most of you know Medicaid, so I won't spend too much time on this, but just to kind of give you a sense of how big it is in our state, it's about 25% of our market. We cover 1 in 4 Nevadans, but when you look at the payer market, we are 24% of that payer spend in the state on healthcare coverage. We cover what we consider a core set of benefits. There are mandatory benefits in every state, and if you ever go to another state and you think that one thing to know is Medicaid is different in every state. You think you know Medicaid, but you don't until you go to the next state. So, but every state does have a core set of benefits, but then they add on optional benefits based on federal law and waivers. We cover 1 in 2 births in Nevada, and we, like I already mentioned, that we make up a quarter of the insurance market, and we are the largest share or source of federal funds in the state. This next biennium, we're estimated about $10 billion in federal dollars. I think Medicaid is an amazing tool for driving improvements in quality and outcomes in the state. One of the things I feel very passionate about, and if I could spend all my time doing, would be driving new payment models and how we and using those payment models to really reward providers for the outcomes that they're doing, right? So really getting away from the widget-based healthcare system and more about driving performance and outcomes. Right now, we're focused on these items here in front of you. One of the things that we know we need in Nevada, and I think most states right now are struggling with access to providers, and we know all the time we hear from our providers, how do I get enrolled? I think some of you that sit here at the table at times are telling me I can't get enrolled or I can't get my payment or whatever is going on. So we're really looking at our processes and procedures internally and trying to figure out what is the burden and why is it there and do we need to have it? And if we don't, then let's remove it, right? Let's get it out of the way. And then the other piece is behavioral health care is a huge, obviously for a lot of our areas at DHHS, but in Medicaid, we are working a lot on behavioral health care and improving that. Maternal child health outcomes in the state are some of the worst in the country, and so this is a big priority. Also transportation and ensuring our rural areas have access to care. That's a big challenge that we are trying to tackle and looking at. And then, like I mentioned, the modernizing how we pay for care and then improving access to preventative and primary care. I won't spend too much time on this slide, but this is basically everything we do in a nutshell. We do not do all of the eligibility enrollment. That is housed at Division of Welfare and Supportive Services. We do have an enhancement item, which I'll walk through, or I think it's in here. Yes, it is, and I'll walk through that in a minute to move some of the eligibility into the exchange for real-time eligibility. So our legislative priorities, I've kind of bucketed them into goals. So the first one here is improving access to timely care. On this item is really looking at our transportation, our non-emergency medical transportation benefit. We often hear that people have a hard time accessing that benefit, and then we know if people can get in to see the doctor, get into their healthcare visits, and they can avoid some of those chronic illnesses and issues down the road, and also ambulance and ER visits, which are much more expensive. So there's an item in the governor's budget on this. Also, new Medicaid payment strategies for providers who participate in our state's GME programs with universities. We do believe there's opportunity if the state puts state dollars down that we can match those dollars and pay those providers a little more, and to really incentivize and reward them, and not just giving them that infrastructure funding for GME, but really thinking about how do we sustain them, right? Because hosting GME and residents is not a cheap endeavor. So trying to figure out how do we support them long term. The second item here is our program sustainability. One thing we constantly are watching is our costs on pharmacy. I think I've mentioned this before. It's a really fast cost driver in our program. We are looking at implementing a new single preferred drug list across all of our MCO plans and our fee-for-service program. So one list. Most states are doing this, so we're excited to join the pack of states, hopefully, to do this. And I think this will really help maximize drug rebates for the state, and there is some savings that we are recognizing in our budget. And as part of the budget amendment that came up last night, some of that savings was not appropriately captured, so now that is. The last item here is really filling gaps in covered benefits. One gap we know in Nevada we have is dental. The mouth is part of the body, and we currently do not cover basic adult dental benefits in this state. We worked with Mercer on is this benefit cost effective? How do we actually look at this benefit? And they actually came back and showed us it is cost effective for the state. So when you look at the fiscal analysis, it is lower than probably what we've brought here before, because we do expect to see savings for this effort. So we have some of those findings. It is not the restorative and some of the more expensive dental. It is just the basic benefit set. Improving access to behavioral health care. I mentioned this earlier. We I think a lot of you already know this, but the state recently signed a settlement agreement with the U.S. Department of Justice for children's behavioral health care. The U.S. Department of Justice 2 years ago found the state out of compliance with the Americans with Disabilities Act. When you provide a state service and you fund services, you have to ensure that you're providing them in a manner that allows people to be in their community and to live like anyone else. And they found that we do not do that for children with serious behavioral health needs. Primarily, this population has no option but to go to inpatient or institutional care in Nevada. So one of the things that we've been working on is really developing that state coverage to ensure that we have home and community-based services for children with serious emotional disorders. Often that includes autism and intellectual disabilities, developmental disabilities. So we're also looking at that co-occurring disorder as well. So the work that we're doing around that is coming together for those kids. But in the budget, we do have several items that are focused on improving access to behavioral health care, including mobile crisis reform. We're going to be looking at the rates and creating a more tiered rate system to ensure that some mobile crisis systems that maybe don't have all of the bells and whistles of the enhanced model can still get paid because we need the service. And then those that do have some of the bells and the whistles of more of that enhanced best practice model, they'll have a higher rate. We're also looking at new rates, a new rate model for community paramedicine, because that is an area a lot of states, several states actually use that model, and it is helpful in so many ways. It keeps a lot of seniors out of the ER, helps with medication management, behavioral health needs, and so we're really hoping that this improved rate model will help really build that in our rural areas. Improved reimbursement for assertive community treatment services, the ACT teams, new quality bonus payment for skilled nursing facilities that participate in the Behavioral Health Complex Needs Population Program, which is BCCP. You may have heard of it called that. Really what this is when we see this a lot where some folks are stuck in the hospital, they have nowhere to go, they need to be in a skilled nursing facility, but the skilled nursing facility is not equipped or is not taking that individual because they have complex behavioral health needs. And so one of the things that the state has created is this BCCP program, this Behavioral Health Complex Needs Program, where we give a bonus payment essentially to those skilled nursing facilities. We're asking to do a quality component to that bonus payment where we are paying those providers that really are partnering with hospitals to ensure patients are not being stuck in the high cost, ineffective, situation for them, the not inappropriate setting, and putting them in the appropriate setting. The other piece here is the PHP, the partial hospitalization program, day treatment, inpatient psych and detox. We're looking at rate increases, as well as we're looking at establishing a new benefit for first episode psychosis model. So covering those services when they're provided under that national best practice model. This is all, just a note, funded through that provider tax that you might have heard about last session, the private hospital tax. We get 15%. So that is funding that. Modernizing Medicaid enrollment and exchange is another priority. We really are looking to help individuals who go through our exchange be able to shop for their managed care plans, for example, and get real-time enrollment and eligibility to compare their provider networks, to see what they're picking, look at quality, really trying to remove any unintended stigma of enrolling in Medicaid and making it more like health insurance. And so that is the goal of this initiative. We do have 3 bill drafts, policy drafts, AB 42, SB 9, and AB 36. SB 9, which I think would come before you all, it's really federal. This one is federal compliance. There's federal law saying, we have to have a third-party payment rules, and this really is complying with that law around. So sometimes if we don't have the same prior authorization process, they'll say that they don't have to pay for it. And so we're complying with federal law to say, yes, no, you do. So this is just clarifying that in law. The first one there is simplifying our administrative process. If any of you have followed our public hearings and public workshop processes, it's a long process for us to implement something. And we really are trying to move away from that, but not taking away from the public and transparency, but also just trying to move faster. So what we're trying to do is if the state or federal government is mandating something that's a benefit, so it's a plus, a new benefit or a rate increase, we can reduce that timeline for all the posting and the public comment and the public hearing. We're hoping that will save us, 4 to 6 months with our workload. The last one there is just a bill around provider appeals, and our DAGs are recommending that we put that in law to be clear that there is a time frame for appealing a payment denial. All right, sorry. Am I going too long? Okay. All right. This mic is really short, and I'm really short. Sorry. Okay. So a couple updates. We, since we last sat here, we've been implementing all the mini legislation that you guys passed, and thank you for that, and the governor signed. We did implement the new private hospital tax program. It brought in a significant amount of money this last state fiscal year, and we are looking at an $830 million net gain for hospitals in state fiscal year 2025. I mentioned earlier the behavioral health services that are going to be funded, that the money there, the $28 million in state fiscal year 24 and $59 million in state fiscal year 25. So this is a lot of new investment for behavioral health, and especially for children's behavioral health. We're focusing on the DOJ work. On the side here, we have the coverage of school health services. We recently got a new grant and have been working with our schools and the Department of Education on how do we get more of our school districts billing Medicaid. We cover a broad set of services, and we looked at the data, and even though half of the counties are enrolled, not many are billing. And if they are billing, it's for your standard required coverage for kids with disabilities. But we cover other things beyond that, behavioral health services, for example. So we're working with the schools to figure out how do we make billing easier, more accessible to our schools. We've heard a couple things like our manual was complicated. We don't cover the types of providers that they hire. We look at more of a medical, clinical background. They're hiring more of the school counselor, a social worker background. So how do we better align our provider types? So we've been working on that. And then dental coverage, like I mentioned, Dr. Benson has been working with our team to implement. We finally did get the federal waiver approved for coverage of adult dental for recipients with diabetes. And if we do get adult dental past this session, that waiver we won't need anymore. So that's what's so frustrating with timelines for implementation. By the time we get something done, it's like it's already so long, so much time has passed. We did get a new CDC grant for oral health, about $1.1 million, and we do have the coverage for the IDD population. We've done a lot of procurements since we last sat here. We are right now in the middle of our statewide managed care procurement. We're expecting awards to be hopefully final in March or April. At least the intent to award letters will be going out. Like I mentioned I didn't mention here, but earlier today, this expands managed care to approximately 75,000 Nevadans in rural areas. It's not our entire Medicaid program. It's just adults, kids, pregnant women, and parents. Also, we are working to amend our 1115 waiver. We just submitted an amendment to add coverage for serious mental illness and institutions for mental disease, and we submitted that to CMS. We already have approval for substance use treatment in an IMD, and this would allow us to also cover those institutional settings with serious mental illness. We've done a lot of work in the Medicare, Medicaid integration area, and we've been working on that 1332 waiver, which we did get approved for Senate Bill 420. And with the governor's market stabilization program and the public option, we're going to bring in together about $300 million over the next 3 to 5 years. Interim updates, again, we did just submit in December our 1115 waiver for federal approval to cover services up to 90 days pre-release for adults and youth who are in a incarcerated setting. We are hopeful that this will get approved. We know many other states have had this waiver approved and are working to implement it. We also did implement housing supports and services into our managed care program. That should be available to recipients this year. I know our managed care plans are working with various providers of these services to get them online and billable. We also are seeking similar services and coverage for housing supports and services in that 1115 waiver amendment I mentioned earlier, which will allow us to cover these services for our fee-for-service population. We did implement, I think next month it comes online, centralized credentialing. I'm super excited about this because it's been a long time coming for our team. You guys passed this funding last session, and it was ARPA funding, and we got extended funding. We are having a centralized credentialing process for managed care, all managed care companies and fee-for-service. Thank you, Dr. Titus. I see you nodding your head. It will hopefully make the process easier. Obviously, anytime you roll something out that's new, there will always be hiccups, but we're excited to get this going. We also have a hospital quality collaborative that we're excited about. All the hospitals we're meeting with, and the MCOs are coming to the same table to work on two of our biggest areas, maternal health and behavioral health. And we're looking at how do we do a new payment model where we're rewarding the hospitals and the MCOs are sharing some of that savings. So we're working on that together right now. We'll see how that goes. Sorry, I'm almost done, I promise. We have been very busy. I mentioned we've submitted a lot of state plan amendments. Some of them are still pending. I mentioned earlier we are more than 90% now fully staffed. The public health emergency unwind has ended, which is great, and nearly half of those that were disenrolled have been re-enrolled. I'm sure Robert Thompson will talk more, if not in his presentation, about that. One thing I wanted to mention that has become really acute for us is data security and cyber attacks and ransomware attacks. It is real. We were affected by the Change Healthcare cyber attack, and it really did shut down operations for our personal care attendant services, and it was very challenging. We had to advance a lot of payments. We successfully navigated it, but I won't say it was easy. And if it happens again and it's bigger and it affects more of our providers, it could be a real budget problem. So there are some staffing requests in our budget to really try to, amp up our IT and our security efforts even more. We have a good team, but we're just concerned about some of the sophistication of AI and all the things that we're dealing with, especially on provider fraud area. All right, that's it. Questions?
Thank you so much. I'll take the first one. You didn't mention your favorite candy.
Oh, that's easy. Skittles.
Sounds good. I'll come back with my round of questions. Do we have any questions from committee members? Senator Stone.
Thank you for the presentation. I think it's the second time I've heard it today. Appreciate the good work you're doing. Can you just elaborate a little bit more on the nexus to Medicaid and the GME slots that we're creating? How many do you think we might be able to do?
Madam Chair, Stacey Weeks for the record. Sorry, Mr. Chair. I'm so used to saying Madam all day. Sorry, did not say. So it's not actually slots. It's going to be supporting providers who will have a slot, right? So if they are providers that are participating with universities, we can use that funding to support those providers through reimbursement in a way we are not today.
The incentive would be a larger reimbursement, I assume.
Mr. Chair, committee members, yes. Mm-hmm.
Any other questions? I just have three real quick ones. Well, let me go through these. I wrote them down. Slide 10, modernizing Medicaid enrollment via exchange. This is more just of a sideline question. I know that you're looking at modernizing how folks enroll into Medicaid, et cetera. Have you guys looked into modernizing the forms that people have to apply for? And is there any efforts that we can help you to amplify that and make it easier for people to access, be more user-friendly? If you can comment on that, please.
Mr. Chair, Stacey Weeks for the record. Yes, I think one of the things we're looking at is making, when someone goes onto Nevada Health Link and enters their information, that would be enough. For those that are what we call MAGI, which are people who should automatically be easy enrolled, there are some people that may not, usually our senior population or people with disabilities, they often have to have a budget, right? A spend down or other issues. So those folks will be referred over to our caseworkers at DWIS, but a majority of individuals should have a very simple, easy process to the exchange. So I think once we get this up and going, that is what we'll have. I don't think we need necessarily statute to do that. We just need to get the systems to stand that up, which is not going to be easy. It'll take a year or two.
With time. Thank
Yes.
you. On the public health emergency unwinding, I know it leads to the next presentation. Are there any lessons learned that you would like to share with us about that process, seeing that nearly half of those disenrolled were re-enrolled?
Mr. Chair, Stacey Weeks for the record. Hopefully we never have to go through a situation where we wait 3 years to renew. I think that's a challenge for everyone. Pandemic happened and we had to do what we needed to do to maintain coverage. I think what we learned from that is communication and just really learning how we need to work more together with our providers and everyone about enrollment and understanding the challenges. I'm sure Administrator Thompson can talk more about some of the lessons that you learned.
Thank you so much. The only thing that I had just in regards to all of this is clearly there's not enough work for you guys to do, so we got to give you more work. I'd like to, of course, bring you back to talk about some of the modernization efforts that you're doing as part of the new standing of a new organization or government entity. But I want to, later on, not right now, we'll talk about more in depth of fraud, waste, and abuse. I think that's obviously something that all of us are very interested in. But I just want to commend the innovative work that you guys have done, and obviously it's mostly on the precedent of leaders. So thank you so much for your efforts. All right, let's go ahead and move on to the Division of Welfare and Supportive Services. Administrator Thompson, whenever you're ready, please.
Good afternoon, Chair and Committee. My name is Robert Thompson. For the record, I'm the Administrator for the Division of Welfare and Supportive Services. Before I start talking about the division, I wanted to tell you about how I got in this chair today. I was born and raised in Nevada. I started kindergarten in 1972. One of the first songs I remember singing is Home Means Nevada. I grew up in a poor part of North Las Vegas and went to work like every other kid, right? In my early 20s, I developed a brain tumor. I got very sick very fast, and I could not get care in Nevada. I had to leave Nevada to go to UCLA to obtain care to save my life, and I went bankrupt from it. And I had insurance. My copay was $250,000, and there was not any help in those days. I was a patient advocate at a hospital in North Las Vegas in my younger years, and I gravitated toward the welfare division in 1996. Obviously, I got well. I'm doing great. I was left with this gosh darn tremor that sometimes I start shaking a little bit, but for the rest of it, I'm doing great and doing fine and have been doing fine for almost 40 years. I've worked for the welfare division since 1996. I have been here over half my life. Pretty much my entire adult life. And when I talk about the health of the individual, I came to the welfare division to make sure that nobody slips through the cracks. And we give it that focus every single day. The welfare division has over 2,450 employees. And for the record, our vacancy rate is 6.7%. That's 6.7%. The only agency that has a better vacancy rate than mine has about 130 employees. We have 2,450. The welfare division processes approximately over 70,000 applications a month. That's 70,000 households that we touch every single month, which can be over 100,000 individuals. We process eligibility for the SNAP program, commonly referred to as food stamps, the TANF program, which is welfare. We contract to do Medicaid eligibility under Administrator Weeks, the Division of Healthcare, Finance, and Policy. We have child care, child support, child care licensing, and energy assistance. And every single one of those families we are able to touch with the overall goal of lifting them out of poverty. Food is one of our number one focuses, the food insecurity, the food stamp program. Very interesting, I pulled the data right before this meeting, and the last month that we looked at the food stamp application data, food stamp data is always a couple months behind, so December is the last full month of data we have. We took 42,900 applications for food stamps. We approved approximately 81% of them. Exactly 5 years ago, we took 35,900 applications, 20% increase in the food stamp applications, but we are approved 6% less. People are coming in, they need help, they're not able to feed their families, they're turning to us for help, but the income guidelines are set by the federal government and people are making higher wages than they ever have. So they're not eligible. We are denying a higher ratio than we have before. Our Medicaid applications, and in Medicaid, people only have to, they really only apply one time and then we renew every month, so it's not a direct ratio as the food stamp program. In the Medicaid program, we took approximately 20,000 applications in the same month. And in the Medicaid program, we normally approve about half of those. The other half we refer to the health exchange because the people that are over income automatically go to the health exchange. We are currently issuing SNAP benefits to over 500,000 Nevadans per month, 274,000 households per month, $93 million a month in food stamps, over $1 billion a year food security into the pockets of eligible Nevadans. But we can't help everybody that comes in. It's a federal program. We do not set the guidelines. We are a pass-through program. The food stamp benefit is not part of our budget. It's not part of the welfare's budget at all. It's 100% federally. We pass through, we put it on the card. Nevada helps pay for that card. The card is 50% paid for by Nevada, 50% paid for by the federal government. And the people that we can't help, we end up spending time to get them over to the food banks, and we do warm handoffs. Of those 70,000 Nevadans per month that we touch, people come into us with a wide variety of issues. They come in, we will come in, and possibly people are working, and we do a Medicaid application for them. We get Medicaid for their kids, and they go on. Yesterday, we had somebody who told us that they were a threat to themselves or others, and our social workers are called in to stop right then and there. When we're dealing with that number of people every single month, every single day, we have the opportunity to touch the most needy of Nevadans. We historically always took applications for assistance at just our offices, and there are about 26 offices throughout Nevada. But under Director Whitley's initiative, when he first became director, so this was a few years ago, we started an outreach program. And our outreach program started with one worker going out into the community and saying, would you like to apply for assistance? Since then, we are servicing over 200 sites in Nevada, out in the community, reaching people that may not have been able to apply for assistance. We go to the homeless shelters, we go to mental health centers, we are in family court, we are in the jails. We meet with prisoners before they are getting out to help stabilize them, because we've proven if we provide those benefits up front, there's a reduced chance of recidivism. So the welfare division, everything we do, everything we touch is with the overall purpose of moving people out of poverty. When you look at our graphs and you look at our charts, you will see that about 5,000 Nevadans are on TANF assistance, the welfare assistance, and people often ask me, why? Why does it stay 5,000? Why aren't we moving those people off assistance? We are moving them off assistance. The average person only stays on assistance about 14 months. Then new families come in. It's a revolving door. We have a strong workforce development team. We move the people into employment, and every single thing that we do impacts the health of that family. Our entire job is health, and sometimes health is child support. Sometimes health is child care. Sometimes health is child care licensing. But everything we do is moving those people out of poverty with a focus on their health, with the overall goal of making sure that no one slips through the cracks. In my time with the welfare division, we were last in the nation, 50th in the nation in food stamp eligibility being accurate and timely. The only territories worse than us were Puerto Rico and Guam, and we used to add them to every charts when we came before you because we didn't want to be last on the list. Since that time, we were recognized by the federal government as being the third most improved state in the nation. We are third best in Western region. We are 13th in the nation in accuracy, and I just received the report for the last federal fiscal year. Nevada was named as the most timely state in the nation when it came to the food stamp program, and it had not happened before, and I'm not sure we can pull it off again, but we're going to knock on wood. So that is a high-level overview of everything we do. We are a passionate agency, and we take care of Nevadans, and I'm ready for any questions that you have.
Thank you so much. You didn't answer to the question of the candy.
Peanut brittle.
Awesome. Any questions for our administrator?
Just a thank you.
Senator Titus?
Great job.
Yeah.
Great work.
No? I don't think we have any other questions, so I think we're good. All right, that concludes our presentations for today. I believe the last agenda item is public comment, but before I get to public comment, I just want to thank all the administrators for their presentations today. I know it's a tumultuous moment in our country, and of course, there's a lot of things going on here in our state. But I just really appreciate all of you for the efforts that you lead on and the teams that you lead in. I'm just very thankful that you took the time to be here with us today. Let's go to public comment. If there's anyone that would like to provide public comment, I ask for folks to please come forward, both here and in Southern Nevada. So we'll start here in Carson City. Just as a reminder, there's a 2-minute limit. So is there anyone here in Carson City? Anyone in Las Vegas? And is there anyone virtually?
Chair, the public line is open and working. However, there are no callers at this time.
Thank you so much. Members, are there any comments before we adjourn? Seeing none, that concludes our meeting for today, and our next meeting will be on Tuesday, February 11th at 3:30 p.m., and our meeting is now adjourned. Thank you so much.